Hi everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the June 2022 issue dedicated to comprehensive management of headache for the otolaryngologist, guest edited by Drs. Joni Doherty and Michael Setson. Here now is the consulting editor for the series, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and today we are speaking with the guest editors of the June 2022 issue of Clinics on comprehensive management of headache for the otolaryngologist, Dr. Joni Doherty and Dr. Michael Setson. Dr. Doherty is assistant professor of clinical otolaryngology, head and neck surgery in the Division of Neurotology at the Keck School of Medicine at the University of Southern California in the USC Caruso Department of Otolaryngology, Head and Neck Surgery in Los Angeles, California. She is the Neurotology Fellowship Director there. Dr. Michael Setson is clinical professor of otolaryngology at Weill Cornell Medical College in New York City, and he is in private practice at Michael Setson Otolaryngology PC in Great Neck, New York. Welcome, Joni and Michael. So I have to say before we get underway that I don't know if you remember, Dr. Setson, but you gave me my very first opportunity to write for Clinics when you edited the headache issue of Clinics several years ago, and I was thrilled to pieces. I had grown up in otolaryngology and in fact in my home because my dad's an otolaryngologist, just revering those what used to be read Otolaryngologic Clinics of North America books back then. So thank you very much for giving me my start.
Thank you for participating in making that such a successful Clinics edition.
And it was so successful that it was high time to update it. And I'm really glad that we have both the rhinology perspective from Dr. Setson and the otology perspective from Dr. Doherty, because headache is something that is very common and quite misunderstood and managed by several different types of healthcare providers. So I think let's dive into the otolaryngologic management. So, Michael, the first question is going to be to you. Why should the otolaryngologist be familiar with the workup of the headache patient? Why shouldn't we just say, go see your neurologist?
Susanna, before I get started, I want to thank you for inviting Joni and I to participate in what is a very, very important Clinics. For the very reason you're asking me this question, we as otolaryngologists on a daily basis, no matter what branch of otolaryngology we're involved in, whether it's otology, rhinology, general, head and neck, sleep, allergy, peds, every one of us sees the headache patient because most of those patients that are coming to us believe that that facial pain and headache is sinusitis. And they believe this because what pharmacy has done, they have told all these patients that all of these facial pains and headaches are sinus problems, and you can manage yourself over the counter with medications. So we play a critical role in determining whether or not it's a primary headache, a secondary headache, and whether or not it's something we, as the otolaryngologist, can manage and treat.
I think that's a really succinct and important point to make. The first article, which is the role of the otolaryngologist in the management of headache, which was written by Hena Murthy and Sarah Mowry, really talks about this. And for our listeners, there's a really good flowchart. Now, you have to have eaten a lot of carrots in your life to be able to read that flowchart because it's quite small. But if you go online or you just magnify it, it's a very nice flowchart of how to think about these patients. And as you said, Michael, not all headache is sinus and not all sinus is headache. And I think to put it into the right perspective. So now, not all headache is sinus, but how do you deal with the patient who does in fact have sinus headache?
So, first of all, as I said, most of these people believe they're coming in with sinusitis. So what we as the otolaryngologist can do is, number one, we got to take a detailed history. we want to ask that patient, do you have nasal congestion, post-nasal drip? Have you lost smell and or taste? And what's the color of the secretions that you're discharging from your nose? Is it purulent? So we can already make a diagnosis on history alone that this facial pain and headache may be due to the nose and sinus. Then, as otolaryngologists, we have the capability of looking in and evaluating the interior of the nose, either with a nasal speculum or a nasal endoscope. We can look at the sinus ostia. We can see if there's purulent material draining from that sinus, and we can complement our diagnosis on history with this exam and say, you know what, you more than likely do have sinus disease, and this is what the cause of your facial pain and or headache is. On the other hand, if there's no history and there's nothing on endoscopy, we can tell that patient, you do not have a sinus headache, you do not have a facial pain and headache due to sinusitis. And then we can go into all the other aspects of what it could be.
It's very nice the way the clinics is normally set up and the way that you have encouraged all the authors to write, to include boxes or sort of easy to follow. You know what? There are buckets, right? There's buckets for acute sinusitis headaches, and there's some nice boxes looking at acute and chronic sinusitis and differentiating those from, for example, tension headaches or medication overuse headaches, etc. So I think there's a lot of information in this full of nuggets article written by Drs. Velasquez and Delgadio. When we learn about sinus headaches and sinus surgery and FES, we learn a lot about contact point headaches, right? We say, oh, you know what? Your terminate is touching your septum, and this is why you're having this. So how do we know, and you talked about endoscope being very helpful, but how do we know, oh, if I adjust this, that's going to relieve a great deal of their headache?
So part of the workup of the patient that may have headaches due to sinusitis, obviously, is to do a CAT scan without contrast if necessary. And many otolaryngologists do have that capability in their offices, so they can get a CT. So on endoscopy, you may see what you've called a contact point, where there's a little spur coming off the septum and touching up against either the middle or inferior turbinate. That could be one contact point. Or you could have what's called contrabillosa, where you have swelling of the middle turbinate, maybe abutting the septum. So that's what the contact point is all about. And it's very controversial as to whether or not contact points actually cause facial pain and headache. And it's well written in that article, and I recommend everybody really go to that article in the clinics to read about it. They have it there, and they have it in the pediatric section as well, because people have talked about it in peds as well. So what do we do then with this contact point? Is it necessarily the cause of the headache? As they say in the article, it's controversial, and it may not be, even though there is a contact point. So what many do, they'll evaluate the nose and say, look, you don't have sinusitis. There's nothing else that I can attribute to the cause of this headache. No migraine, no tension headache, nothing else except we see this contact point. Now, we can inject that little contact point if you're coming in today with headache. And if that headache goes away when we've injected an anesthetic into that contact area, this may tell one that the contact point is responsible for your facial pain. So what do? It's controversial as to what to do. And as they list in the article, both sides of the argument, some say do something, others say it's not the cause. But if you truly believe that this may be the cause, then the best thing to do for that contact point is to either take down the concha bullosa or do a septoplasty. And in articles that were written, there was an article by Welch Lusion listed in their article there, where they found that roughly 30% of people got better, 30+% had significant improvement, and 30+% had no improvement. So it's rather controversial as to what to do, but it's something that at the end of the day, if nothing helps, this needs a lengthy discussion regarding risks, benefits, and alternatives with the patient, that this may or may not help, and then you invite the patient to participate in that decision-making.
So, you've included an article called Novel Devices for Sinus Headache, and this is written by Migliani, Solar, and Schlosser. Can you tell us just very briefly what do microcurrent devices and acoustic vibration devices do, and are they worth trying?
Because headache is such a complex issue, and do you want to only take analgesics and painkillers, whereas there may be something where they can stimulate the trigeminal nerve with noises? That's what the acoustic vibrations issue talks about, that they stimulate the nose, and they have found that this may be something that will help with facial pain. Now, it's very early on in their development. It needs many more centers to determine whether or not this is cost effective, but it's the beginning. That's one aspect of a possible novel device. The next one is whether you can try neuromodulation with electrical and or magnetic stimulation. Now, wouldn't this be wonderful if a patient could use one of those two devices rather than painkillers and analgesics? So those are the two devices that are being looked at. It's very early on. And when I invited Ron Schlosser to talk about this, he too said this is new, it's early on. And I think we need to await studies from them and others to determine whether these devices can really help facial pain.
That's one of the beauties of clinics, is we can see what's old, what's new, what's being tried. There are some nice figures in there. If you guys want some clue as to what we're talking about, there's some really nice figures in that article. So now, our listeners will know that I always become very happy when we switch over to an ear topic. So let's talk with you, Joni, Dr. Doherty, about something that gets lumped a lot, vestibular migraine. And we know that neurologists approach headache, frankly, much more systematically and much more rules-based than otolaryngologists approach headache. But we do have patients who either have been told by other people that they have vestibular migraine, or they've decided they have vestibular migraine. How do we parse it out? How do we really come to that diagnosis for them?
Well, in my clinic, I typically take a very thorough history, about associated symptoms that occur with dizziness and, vestibular migraine, for example, and trying to differentiate between other diseases of the ear, such as Meniere's disease, which is by far much less common than vestibular migraine, with other causes of dizziness that are more common, like benign positional vertigo. They don't typically have headache pain or other associated symptoms like photophobia or phonophobia. So I'll ask about all of those things. I'll ask about visual disturbances that may be occurring, and if there are certain triggers that the patient can identify, such as jet lag or not getting adequate sleep, skipping meals, that would clue me into more of a vestibular migraine diagnosis. Also, if the patient has a history of classical migraine, it can morph later in life and turn into vestibular migraine, even without a headache, in some cases. But they typically will have the associated symptoms of migraine, like the photophobia, phonophobia in some cases, visual disturbances, and, sometimes even have a unilateral headache pain. In our specialty, unfortunately, I think that Meniere's disease is overdiagnosed when, in fact, it's probably vestibular migraine that is going on. And that's because sometimes the diagnostic criteria get confusing between Meniere's disease and vestibular migraine for otolaryngologists. For example, that the patient might have tinnitus or fullness in the ear, and in some cases, that may be the aura of the migraine coming on. Whereas conversely, Meniere's disease patients also present with tinnitus and oral fullness in the affected ear, but they'll have a measurable hearing loss in typically the low frequencies. And they'll have episodes that last for hours rather than days, which vestibular migraine patients can experience. There are some really good tables in this article done by Dr. Krishnan and Dr. John Carey at Johns Hopkins. The diagnostic criteria are important, and they show the prevalence of the vestibular migraine as being around 9 million people in the United States versus benign positional vertigo, which is the next most common cause of vertigo, affecting about 5 million people, and Meniere's disease affecting less than 700,000 people in the US. It's really important to consider the more common diagnosis and to look at the tables in this article that describe triggers besides food triggers, like adherence to a regular sleep pattern is really important. And if that gets disrupted by jet lag or anything else, insomnia, then it can trigger a migraine. Skipping meals and certain food triggers that are well known, like MSG, aspartame, chocolate, red wine, the typical things, monosodium glutamate or MSG. It's commonly found in a lot of junk foods and fast foods and packaged foods. The other really useful part about this article is the medications that can be used to treat acute vertigo, the nausea and vomiting symptoms, and then actually prophylactic medications that can be used to treat the whole migraine process. And it's been shown that treating the migraine, the underlying problem with vestibular migraine, is what will really treat the vertigo episodes as well.
Vestibular migraine is so difficult on many fronts because I think it's challenging to diagnose. We do have an issue of clinics devoted to complementary and integrative medicine and nutrition, because it's something where everyone's coming in with taking this supplement or that supplement, and it's sometimes hard to understand what they are treating themselves with, or perhaps what we should be recommending or recommending against. And I think that you're right. Those tables in the article by Carey really are terrific for trying to understand the more and less common supplements so that we can understand how to deal with them. What about vestibular assessment in people with headache and dizziness? So I know that you put in a really good article by Doctors Bassett and Van Strom. My experience is that if you have a migraineur and you put them through a VNG, they might not like you very much. So, but sometimes you have to do it, right? Sometimes you really do have to put them through some paces. So can you help our listeners understand when you might order vestibular testing on these patients and when you really think it's not necessary?
In cases where you're not sure about the diagnosis, like those kind of things that are sort of on the cusp of maybe you're thinking that this is looking more like Meniere's disease, or it's looking more like maybe a superior canal dehiscence, you want to do some testing as well as imaging to really, confirm or refute your diagnosis. I would say for a patient who you suspect has vestibular migraine, you can start out with some other tests besides the calorics, which are part of a video nystagmogram or electronystagmogram. They are the part of the test that will really cause them to go into vertigo. And most patients with vestibular migraine have some underlying motion sickness. And so they're really not going to like you because they're going to feel pretty bad for the rest of the day. And sometimes it can even trigger a migraine. So we can do VEMP testing, which stands for vestibular evoked myogenic potential. And we can even get an idea about whether this might be vestibular migraine, because there's some evidence that the results are either stronger supporting for vestibular migraine or for Meniere's disease. So if they exhibit an increased amplitude on the VEMP, for example, that suggests that it possibly could be Meniere's disease, and that would be in one ear only. Other tests that can be done are the video head impulse test, or VHIT, and that tests all of the canals and the utricle and saccule of the vestibule. So it tests basically the whole entire vestibular organ, and it can give us an idea about whether there's a miscommunication with part of it, or one of the nerves, the superior vestibular nerve or inferior vestibular nerve may be affected more than, another part. And that will stimulate us to maybe get certain imaging or look further into the diagnosis.
So that segues beautifully into my next question for Dr. Setson. So what imaging studies do you do when working up a patient with a headache?
As otolaryngologists, the first thing we're thinking about is this sinusitis? So obviously, if we've ruled everything out and we're thinking this is a sinus disease and I want to document it radiologically, the best X-ray to do is a CT sinus without contrast. Now, if I'm thinking it's not sinus disease, but I'm more concerned about a primary cause of headache, be it tension headache, which is the commonest cause of headache, migraine, the second commonest cause, or cluster, believe it or not, imaging won't help you with any one of those because imaging is usually negative in the three commonest causes of primary headache. So you don't need to image for that. But if you're not sure and you think it may be a secondary cause, you've ruled out sinusitis on your CT sinus, you should do a CT of the brain without contrast. Now, the bottom line is we really don't want to overstep our mark as otolaryngologists and become neurologists and neurosurgeons. So obviously, to protect your patient and to protect yourself, if I really did think this was a secondary cause of headache due to something intracranial, so we should rather refer this to a neurologist or a neurosurgeon. And all this information is well documented in the chapter where they go through all the different radiologic recommendations. But the best X-ray then would be an MRI, of course, either with or without contrast, looking for something intracranial. But if it is a bleed intracranial and you wanted to get a quick X-ray, you could do a CT of the brain without contrast. It'll obviously show you a bleed. But that's not really something that we do. What we want to do is we want to determine, is this something acute sinusitis, which many people have a CT in the office, they can get it within the context of that office visit. But if you think it's something more significant and there's some red flag warnings, such as cranial nerve abnormalities or significant visual deformities or neck stiffness or high fevers, you should embrace a neurologist, let them do the MRI, but that would be the next step for us as otolaryngologists.
This article by Lerner, Sheikh Baheh, and Go, like all articles that feature neuroimaging, have some beautiful pictures and some scary pictures. Like really a scary one, if you want to hang something up on Halloween, is figure 4, which shows extensive pneumocephalus with a cribriform defect. Judicious use of imaging is what I'm hearing from you. As we know, in the United States and probably around the world, patients have access to their imaging reports. So something that sounds completely benign to us has so many words in it that it's really important that the patient understand not only why we are ordering the test, but that we're actually going to go over the findings to say, this is a lot of words, but it really doesn't mean much, or this is just one word, but this word is pneumocephalus. So I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and I'm having a great time talking about comprehensive management of the headache for the otolaryngologist, which is the June 2022 issue. And I'm speaking with Dr. Joni Doherty from the University of Southern California in Los Angeles, and Dr. Michael Setson from Cornell Medical School and private practice in Long Island. So let's get back to Dr. Doherty. Idiopathic intracranial hypertension, or IIH, is something that is actually highlighted in the article that Michael and I just talked about in terms of imaging. But can you talk to us, based on the article written by Drs. Pan, Vanstrom, and you, what we should be thinking about in terms of suspicion for IIH, and then what about a treatment algorithm for that?
So yeah, this article goes over intracranial hypertension in detail and refers to primary causes and secondary causes. It gives the modified Dandy criteria for diagnosis, as well as the little bit more detailed Friedman diagnosis criteria for intracranial hypertension, and then gives an algorithm for treatment based on majorly whether there is immediate risk or if the vision is not at immediate risk. So they divide it into non-fulminant intracranial hypertension when there's no immediate threat to vision, and fulminant intracranial hypertension when there is an immediate threat to vision. And in that case, it goes on to recommend shunting the CSF away immediately, within 48 hours. And when there's no immediate threat, other things can be done that may take a little longer to take effect, like weight loss, CPAP if there's obstructive sleep apnea present, which can be a secondary cause of intracranial hypertension. I was going to say idiopathic intracranial hypertension, but sometimes you can actually find a cause for it when it's secondary. And then considering medications for treatment. There's a treatment algorithm table in this article that goes over some different medications like acetazolamide and topiramate as a secondary if the patient doesn't tolerate acetazolamide, because it can be poorly tolerated due to side effects, mainly paresthesias. And then even further for fulminant intracranial hypertension, optic nerve sheath fenestration can be done to save the vision. So it goes over that all in incredible detail.
So I will tell you guys, one of the things I do counsel patients if I'm starting them on acetazolamide is not just that they can get those fingertip and perioral paresthesias, but actually carbonated beverages taste terrible. And once I tell them that, when they experience it, they get less freaked out than when suddenly their carbonated beverage, which they shouldn't be drinking because it's junk food, but what are you going to do, starts to taste bad. Joni, let's talk about neuralgia, atypical pain, and facial pain. And you included 2 articles on this in this issue of Clinics. And the articles cover geniculate, trigeminal, and glossopharyngeal neuralgia. And then they talk about medical surgical options for facial pain. Can you give us a couple of pearls from these 2 articles?
Dr. Shibata did an excellent job of describing the differential diagnosis of these atypical facial pains, and then went over medical and surgical treatments for them in Table 1 in pretty good detail for first line, second line, and third line medications used to treat these. And then in the second related article for facial pain, this was written by a neurosurgeon, Dr. Darren Lee, is the senior author, and he writes about surgical microvascular decompression for atypical facial pain when a impingement can be identified on imaging, such as impingement of the 9th cranial nerve or glossopharyngeal neuralgia or for trigeminal neuralgia. Sometimes we can identify just via MRI. There might be an impingement at the root entry zone of the nerve, the brainstem, and then that can be decompressed surgically. So this is basically, first article talks about medical treatments, and then the second article talks more about the surgical treatments and gives a nice algorithm for this type of pain, whether, basing the diagnosis on whether it's constant or intermittent, sporadic, and triggering factors. And there's a tiny little table that, again, you'd have to probably look at online or enlarge it or wear some really powerful reading glasses in Figure 1.
And I think this can be very challenging, right? Patients have gone to various types of practitioners. For example, they may have seen a rhinologist or a general ENT person who says, oh, this is definitely a contact point headache, right? They may have undergone procedures. So I think that these are more elusive. Is that right, Joni, in terms of actually making that diagnosis?
Yeah, I would say so. I definitely feel that way in my practice. It's difficult to diagnose them if there's nothing that can be seen on imaging and the symptoms don't follow the typical diagnosis. Like, for example, both glossopharyngeal and trigeminal neuralgia tend to be aggravated by teeth brushing. So the type of pain that they get will be aggravated by certain activities.
Thank you. So Michael, another challenging thing, and I must compliment both of you, because first of all, it's hard to tackle headache, and then to tackle it with this depth of interest and really covering the most difficult parts of headache is really an incredible accomplishment. So speaking of hard to treat patients, what about headache in the pediatric or adolescent patient? Like, how do we focus our thoughts when we are encountering that child or young adult who is with their parent, and there are definitely psychological overlays because this child usually, when they're bad enough, has missed a great deal of school, has changed from being really a top student or a top athlete to somebody who's really quite sidelined educationally and with sports, with their friends, because of their headache. So how do we participate and help these kids get better?
You're right. This is an interesting and a difficult topic, and it's a great article written by Vijay Patel and colleagues, whereby they tell you that headache is actually quite common in the pediatric age group. We think they're only getting otitis media or tonsillitis, but they get headache as well, and they get migraine as well, which is, something that many don't believe. And it's the commonest cause of headache even in the child. In males, it can start around at 7, in females at 11. So it's interesting that both the young boys and young girls can have headache. And believe it or not, that's a challenge. And once again, the chapter discusses all aspects of headache, primary and secondary causes, how you work it up, how you diagnose it. And I would encourage people to read it. But in a nutshell, it's what we do as otolaryngologists. We'll take a history. First of all, we want to determine, is it a rhinologic cause? Is it an otologic cause? Is it psychological, as you've said? Once again, a good history from the parents, maybe even the child, as to what's going on. If it's migraine, let's find out. How long does this headache last? Is it 4 hours to 72 hours? How often does it come on? Do you have visual aura associated with it? So we can determine if it's migraine. Could it be a cluster headache? Could it be rhinosinusitis causing the headache? We'll then look into the nose. Many kids don't like you to put in a rigid telescope into the nose, but believe it or not, even in the young child, you can gently pass in a flexible telescope with a little bit of encouragement, and you can document whether or not they have a rhinologic cause. Obviously, if you don't see anything and you feel it's not in the domain of the otolaryngologist, you may want to refer that patient to a pediatric rhinologist. On the other hand, if you think it may be sinus related, what X-rays should you do? We try not to do X-rays if at all possible because of, radiation exposure. You don't want to get an MRI if you think it's sinusitis, but if you think it's something intracranial, an MRI with gadolinium obviously would be something you could think of. If you think it's maybe acute sinus disease or chronic rhinosinusitis, a CT without contrast, may be something you could think of, but wait until you've exhausted all aspects of your diagnostic acumen before you do a CT. But in the pediatric age group, if you absolutely need to do a CT, then you can do the CT. Whether or not the young child will stand still or sit still is another complexity that we have to deal with. But in the older child, they will usually cooperate and one can get a CT. So you'll make your diagnosis. It's either rhinologic or not, otologic or not. Is it primary or secondary? And then you've got to decide if you want to deal with migraine, be it the pediatric child or the adult child. Many of us in otolaryngology are starting to treat, migraine. You'll treat them with a painkiller. I'm not going to give a child a triptan, but I may give them a simple analgesic. But on the other hand, if I think it's a more complex case of headache, that's why we have referrals to neurologists. We should embrace working with all our colleagues and not try to take on the headache patient alone, be it adult or pediatrics. We want to work with others when it comes to the headache patient, and we want them to work with us. We want them to send their patients to us as well if they think it may be something ENT related.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I want, just for the sake of our listeners, to read the list of things that are listed as headache red flags, particularly in children. And this is really for people seeing patients either in the emergency room or in the inpatient setting who have severe headache. This is for children. And the things that should worry you are abnormal neurological examination, abnormal visual examination, an acute severe headache, confusion, consistently worsening morning headaches, comorbid seizures, a duration of headaches of less than 6 months that is so bad that they're now in the ER, a progressive course of their headache, sleep-related headaches, symptoms of systemic illness, worsening headaches when they perform a Valsalva maneuver, and vomiting. So I'm just reading that in because I think it's really important. When you see headache, your brain can automatically just say, oh, it's just a headache. No, it's not just a headache sometimes. And as Michael, you said, headache is really common in children. So when they come in, we need to really think about what's bringing them in for this kind of care. Another thing that is very common and seems to get shuttlecocked between dentists and ear, nose, and throat doctors is TMD or TMJ, or temporomandibular dysfunction, or temporomandibular joint dysfunction. So, Joni, every time a patient tells their dentist they have an earache, they say, oh, it's your ear, it can't possibly be your TMJ. They come in to see us and we're like, your ear's fine, this is your TMJ, and they're just sort of stuck in the middle. So how do we stop that?
Well, we have to take a detailed history on what aggravates the pain, when does the pain come on, where exactly is the pain occurring, even looking at the surface of the teeth for any evidence of grinding or clenching. Sometimes they'll have little cracks in their teeth, or if they have a history of having a cracked tooth kind of out of the blue, that's a big clue. I often ask them if they've ever been told by their dentist that they grind or clench their teeth, whether they've ever tried using a night guard. Sometimes these people have a remote history of using a night guard when they were younger and now present with this ear pain that, there's normal exam, hearing test is normal, and I palpate the muscles, the temporalis, masseter muscle, and the joint itself, see if I can feel any crepitus there. And then I typically talk to them about, the most common thing with a normal ear exam that causes ear pain is temporomandibular joint syndrome. And sometimes I'll send to therapy. In this first article, from an ear versus a dental related standpoint, it explains the diagnostic criteria, which are, pretty straightforward for most of us, seeing this as a regular occurrence with ear pain being the presenting symptom. And then they go over the management too. The second article, that is from more of a dental standpoint, really gets into the anatomy of the muscles involved with temporomandibular joint syndrome. And there's some really excellent drawings and also some imaging that show the changes that occur in the joint. There's a panoramic that shows joint changes, and then some other like MRI images of the temporomandibular joint that show the joint changes that can occur over time with temporomandibular joint disease or disorders syndrome.
And I think, again, it goes to communication with the patient, right? This is why I think this is happening, or this is why I don't think. And possibly getting on the phone and talking to the person's TMJ doctor, their dentist or their oral surgeon, and saying, hey, this is what I'm finding. Can you help co-manage? Because I think the days of those silos where we only did one thing and they only did another thing are done, thank goodness. So, Michael, let's talk about pregnancy. Now you have a pregnant lady. You're not going to get imaging on her. how do you manage her headache? How do you give her the best quality of life during her pregnancy?
It's interesting. It's not like the pregnant patient's going to come to us with anything but thinking they have sinusitis. So, it keeps going back to sinusitis. It's not like the pregnant woman with migraine is necessarily going to come to us. They're coming to the otolaryngologist thinking they have an ENT-related cause. Doctor, I have this sinusitis. It's giving me a headache. What we've got to do, and we keep saying this over and over and over, take a history, do your diagnostic evaluation. We can scope the pregnant patient. So we need to make that diagnosis and let them know your headache is not due to sinusitis. It may be migraine. Now, migraine is very common during pregnancy, as is tension-type headaches. So we go through this in all different pediatrics get the same things, pregnant women get the same things, but we as ENTs need to determine, is this something we should treat? Is it an otolaryngologic problem, or is this something for which they should go to their OBGYN, or should their neurologist see them? So no CT unless absolutely mandatory. They don't need an MRI, but if you did need to do an X-ray, that would be the one without contrast. And then if you did think it was sinusitis, we'll give them nasal saline sprays. We can give them topical steroid sprays. Initially, there was concern, but there's no more concern that the topical steroid sprays will cause any problems. You can give them, painkillers during the pregnancy. In particular, acetaminophen shouldn't cause any problem first, second, or third trimester. Later on in the pregnancy, you can give things like the NSAIDs, but apparently you don't want to give those in the first trimester. But this needs a discussion as well with their OBGYN. Tell them that I think you have sinus disease. This is what I'd like you to take, as they list in the article. But then, have a discussion with the OBGYN. Either you can call the OBGYN or they can call them. And maybe, Joni, you want to comment a little bit as well, because you were involved in that article.
Everything that you said is correct. I think that it does need to be handled carefully in a pregnant patient, because we want to hold back on prescribing medications or over-prescribing. And also, sometimes they might not even want to undergo a CT scan because of the small amount of radiation that they're exposed to and with that. So you've got to consider these different things. And in pregnancy in particular, there is an increased risk of, thrombosis due to the circulating hormones. And so, life-threatening headaches have to be considered, especially considering the severity of the presenting headache.
And then a thing that I found very helpful in this particular article in Table 4 was you guys gave a safety profile of commonly used medications for rhinitis and sinusitis in pregnancy. So they're commonly used medicines that we use for everybody, but the addition of that safety profile is really helpful. So if you happen to have this issue of clinics in your office, you can just pull it off the shelf and make sure of the safety profile. You can kind of make yourself comfortable with it so you know what is the least likely to have any sort of negative effect on the pregnancy or the baby when you need to give it. Because if somebody's got acute sinusitis, acute bacterial sinusitis, and they're pregnant, they need to be treated. Wouldn't that be correct, Michael?
Yeah, no, so you can give them an antibiotic if they have acute sinusitis. You could give them ampicillin if they're allergic to penicillin. You can give them azithromycin. So those two drugs can be given. And as you said, it's listed in that table, which I would encourage people to look at and keep, should they ever encounter a pregnant patient with sinusitis.
And then as we come to the conclusion, Joni, can you talk to us about what is a nummular or a side-locked headache, and how do we identify it, and then what do we do about treating it?
So nummular headaches are headaches that occur in the same exact spot. It can be like a circular area. Diameters differ between patients. but it's the same exact spot on the head, and it can be intermittent, and they can be treated with local injections to that area, usually treated by a neurologist. Side-locked headaches are headaches that occur only on one side of the head. That the differential includes migraine, all the neuralgias that we've talked about. And this article nicely circles back to all the different diagnoses that we need to consider when a patient presents with a side-locked headache. And they also have a nice summary at the end for clinical care points, mentioning that ophthalmologic disorders and vascular disorders represent the red flag diagnosis, and they require careful assessment and further workup when there's a sudden change in vision or sudden cranial nerve deficit. Also, temporal arteritis needs to be considered. The physician can palpate the patient's temporal area where the temporal artery lies, and then also can assess for any diplopia, which may go along with that diagnosis. And referral to a neurologist is most common with the nummular headaches. They are more familiar with doing the injections that are required for those type of headaches that occur in a single area repeatedly.
So we've come to the end of this issue of Clinics. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. I've been talking with Dr. Michael Setson and Dr. Joni Doherty, who are the guest editors of the June 2022 issue called Comprehensive Management of Headache for the Otolaryngologist. It's a terrific issue. I think it takes a common and somewhat frustrating problem and it breaks it into manageable pieces where we can actually help people get better. I think it promotes crosstalk between subspecialties and different areas of medicine and dentistry, and really allows us to be very proactive in terms of the management of the patient with headache. Dr. Joni Doherty is Assistant Professor of Clinical Otolaryngology Head and Neck Surgery in the Division of Neurotology at the Keck School of Medicine at the University of Southern California in the USC Caruso Department of Otolaryngology Head and Neck Surgery in Los Angeles, and she is the Neurotology Fellowship Director there. Dr. Michael Setson is Clinical Professor of Otolaryngology at Weill Cornell Medical College in New York City, New York, and in private practice as Michael Setson Otolaryngology PC in Great Neck, New York, which is on Long Island. I want to thank you both, Michael and Joni, for joining me today and for putting together really a terrific issue of Clinics.
Sujana, I want to thank you. I really enjoyed doing this with Joni, and I'm hoping those listening into this will have learned a lot in how to manage those headache patients that we see on a daily basis.
Thank you. I really enjoyed this experience as well, working with Michael and working with Sujana. It's been an incredible experience, and I've learned quite a lot through it.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on comprehensive management of headache for the otolaryngologist, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.